I thoroughly enjoyed this session. I'm aware that some of you may be getting hangry as lunch approaches, so I'll try and make this quick and to the point. So this last section, in this session, looking at complementary imaging modalities to echo, considers the role of nuclear cardiology to complement echo, to help us to dissect out what's going on in these challenging cases. I have no disclosures to disclose, no financial conflicts of interest. This objective slide really can be pared down into the which, the how, and the wow. So the first thing we're going to look at is which conditions can nuclear cardiology be complementary to echocardiography. The how is how are they complementary? Is it in diagnosis? Is it in management? Is it prognosis? And the wow, we've had a lot of wow already today. I haven't got any videos to show you like my colleagues, but hopefully we'll have a lot more color and you'll leave the room with a healthy glow from the radiation. So when I thought about what we should discuss, I was also aware that time was of the essence. It was approaching lunchtime. And so although we could have discussed any one of these, I thought we'd choose the first two. In part, they use the same techniques, which reduces the number of physics slides that I need to show you. So we're going to be looking at endocarditis and cardiac device-related infections, and then we're going to move on and look at sarcoidosis, in particular cardiac sarcoidosis. And both of these techniques use FDG PET imaging. So a few words about PET imaging. So PET imaging uses radio traces that decay by positron emission. The positron travels a short distance. It hits an electron. That collision is an annihilation collision. It generates two diametrically opposed photons. So we need a specialized camera to pick that up. You can't use the traditional SPECT cameras because you have two diametrically opposed photons being released. The tracer that we're going to be considering is FDG glucose. As its name suggests, it's a glucose analog. It's readily taken up by metabolically active cells such as leukocytes, monocytes, and macrophages in areas of inflammation. And once it's taken up into those cells, it's quickly phosphorylated and it's retained within the cells. So this is our first case, and it really demonstrates the utility of FDG PET within endocarditis, and particularly prosthetic valve endocarditis. So this was a 77-year-old man who had severe aortic stenosis and underwent an uncomplicated bioprosthetic aortic valve replacement in the fall of 2016. He then went for his stay vacation down in the US over the Christmas and winter period. We don't have the details of his admission there, but he needed a permanent pacemaker implanted. He then returned to Ottawa in the May of 2017 with a febrile illness. And he presented to hospital not feeling quite himself with temperatures. And as you might expect, he had a thorough workup with repeated blood cultures, a transthoracic and a transesophageal echo. And all his images were unremarkable. The valve was well seated. There was no vegetations on the aortic valve. There was no paravalvular leaks. There was no vegetation. His blood cultures were negative throughout his admission. So he was discharged, but he kept under continued follow-up. And I think that's very important here. I think that these patients that we see with suspected endocarditis, we need to make sure that we have tight follow-up plans for our patients. And because of a persistent pyrexia of unknown origin, his cardiologist asked for an FDG PET. And what that showed is shown here on the left-hand side. And I know that many of you may not be as familiar as some of you are with these images. So let me just talk you through what we see here. So this is a whole body FDG. I've shown the patient in profile so that we can identify a lot clearer where the FDG uptake is. Now the main metabolic substrate for the brain, at least hopefully even now at this time of day, remains glucose. The extra glucose is excreted in the kidneys, so we see the collection here in the kidneys and also in the bladder. So the two abnormalities on this whole body FDG is this uptake here in the aortic root, and there's another little bit here at the side of the aortic root. He also, interestingly, has high uptake here, which turned out to be in the right femoral artery, and I'll return to that point in a minute. So we have whole body FDG images. We map those to a CT attenuation. Is that better? That's great. So we map those images to a CT attenuation corrected map that's obtained at the same sitting. And you can see here there's avid FDG uptake around the aortic root of this bioprosthetic aortic valve. The patient had extensive mitral annular calcification, which is this whiteness here. And then this red area here, or orange area, is uptake in the mitral valve too. And coincidental with the patient undergoing this FDG PET, he actually returned to hospital with septic shock, and he was found at this time now to have gram-positive bacilli of Corynebacterium diphtheriae in his blood cultures, and he underwent a TEE at that setting and a transesophageal echo, both of which were positive. The transesophageal echo showed an aortic root abscess, and the transthoracic echo had demonstrated vegetations on the mitral valve. I've tried to cut my slides down, so I've not showed you lots of echo pictures for the sake of time. He was treated with vancomycin and underwent early surgery with a mitral valve regurgitation and a redo aortic valve. So several things we can take from this image. We see that this was a very useful technique for detecting prosthetic valve endocarditis. It also demonstrated native valve endocarditis, and it also picked up a infectious embolism. And so the question is, okay, well, we can detect these things, but how useful are they for us? Some of you will be aware there's a schema of the utility of imaging techniques. And one of the important things on the hierarchy of imaging techniques is what's the utility? How does it change patient management? So this is a group from Madrid in Spain, and they went back and looked at a retrospective study. They've begun to do FDG PETs now on all their patients with suspected endocarditis. And so they look back, and of 47 cases of proven endocarditis, about 50% of them had native valve endocarditis and 50% had prosthetic valve endocarditis. And of those patients, this was primarily a study looking for infectious embolic events and what the implications are for our patient management. And 3/4 of the patients were found to have infectious embolic events. So then they went back and looked back and matched these patients to historical controls from their center. And what they found that using FDG PET imaging, they found a 50% increase in the pickup rate for infectious embolic events. So many of them, you will say, well, that really doesn't make any difference. These patients are going to get 6 weeks of antibiotics. Does it really make any difference? Well, it did in their group. What they found was that having found evidence of embolic infectious events, it actually increased treatment time. Most of this was done in outpatient, so it didn't increase inpatient stay. Well, importantly, but not statistically significant because of the numbers involved, it actually reduced relapse rate, which can be very, very troublesome in these patients. So as mentioned in the introduction, the new European guidelines looking at endocarditis actually now recommend FDG PET for prosthetic valve endocarditis as a major criteria, as is, my colleagues would have touched on this, but in CT imaging, if you see a paravalvular abscess and aortic root abscess, that's now a new major criteria. In terms of these embolic infectious events, well, where do they score in the criteria? They're now classified as a new minor criterion. So they're classed essentially as a vascular event, as we used to classify it in terms of the minor criteria. Another type of infection that's very troublesome within the heart is cardiac device-related infections. And this is an 80-year-old lady who returned a year after her permanent pacemaker was implanted, and she was complaining of some soreness and redness over her generator site. She underwent an ultrasound to look to see if there was any fluid collection there. There was no fluid collection seen. So she underwent an FDG PET to see if she had infected leads, did she have an infected generator site. And what was found, again, this is similar to the whole body FDG image I showed you earlier. This is FDG uptake around the pacemaker generator. This is FDG uptake within the heart. We do see some normal variations in terms of FDG uptake, and this is just normal lateral wall FDG uptake. But what was important, we didn't see any of FDG uptake on the leads. Now, I know my colleagues will tell me if I don't mention this, but one of the issues with nuclear medicine is attenuation, or blockage, if you like, of the gamma photons on the way out of the patient towards the camera. So we have algorithms in our reconstruction to account for these lost photons, and it's called attenuation correction. And one of the problems when you're dealing with prosthetic objects or metal objects is that they will attenuate or limit the flow of the photons away from a hot area. So it's important when we're looking at FDG imaging that we look at both the attenuation-corrected images and the non-AC corrected images. And what you see is the generator remained hot when we took away some of the additional counts that the computer would have added in as part of our reconstruction. So in terms of device-related infections, in this patient, it was extremely useful, and the patient went on and had their generator removed. Staph aureus was grown from the tissue from the generator site. The lead didn't need to be removed because there was no evidence of infection of it, and the patient did very well. The role, where does cardiac device-related infections, how does that score in terms of FDG imaging and the European Cardiac Society guidelines? It scores a 2B indication. So if you have a patient who has a device-related infection and you're not sure, how much of the device is infected or whether or not this is general infections or just an irritation, then you can consider doing FDG PET imaging for that. I see my timer's on 10 minutes and we're halfway through, so we're doing very well. So I want to change tack now and look at sarcoidosis. Sarcoidosis is a bit like the Montreal Canadiens. They're very enigmatic as a hockey team, and sarcoidosis is a very enigmatic disease. We don't really know what causes it. We know it has pathological characteristics, such as these non-caseating epithelioid granulomas. It most often involves the lung, but can involve the heart, the liver, and other organs. Its prevalence is about 5 in 100,000, but that prevalence may differ in different populations. And cardiac sarcoid is very challenging to diagnose. It occurs in approximately 5% of those patients with pulmonary disease. However, from MRI work, where we learned that perhaps as many as 50% of patients with pulmonary sarcoid have cardiac sarcoid, it's just silent. What about isolated cardiac sarcoid? That occurs in about 3% of patients. I called it an enigmatic disease. This is 4 different patients with sarcoid. And the patient on this side here primarily has lung and splenic involvement. This patient, all these dots, is sarcoid granulomas within the bones. So this is mainly bony sarcoid. This patient here has uptake in the lymph nodes here around the celiac axis, the mediastinal nodes, and also within the spleen. And then lastly, this patient here has skeletal muscle sarcoid as well as cardiac sarcoid. So it can affect different patients in different ways. I put this up partly so that you didn't ask questions about it and that we had a reference point. So because it's such a challenging diagnosis to make, there are a lot of rules and regulations about doing it. Essentially, you do need a histological diagnosis. In terms of cardiac sarcoid, it can have a patchy distribution. So the yield of doing cardiac biopsies is not high. So often the second line here in terms of clinical diagnosis is sought. So we'll see if we can find a superficial lymph node that's been affected and aim to target that in terms of biopsy, looking for extra cardiac sarcoid. The patients, in order to have cardiac sarcoid, obviously have to have demonstrated some manifestation of cardiac sarcoid, whether that's reversible arrhythmias, reversible heart failure, sustained heart failure, or FDG uptaking, or classical features on cardiac MRI, or even on SPECT imaging with gallium. And other causes of these cardiac manifestations have to be excluded. So this is a 45-year-old lady who presented in the periphery and was referred to the Heart Institute in Ottawa for a permanent pacemaker. No other cause was found for a heart block, and she underwent FDG imaging. And what these images demonstrate, again, so this is the whole body FDG, and it's important when we look at these images that we consider all of the different types of images. So the FDG imaging, the relative FDG uptake imaging, the attenuation-corrected images, and also the perfusion imaging. So what I'm going to just tell you is, so this is the FDG imaging picture here. This top row here is perfusion imaging, and the short axis slices. The bottom row here is the short axis slices showing relative FDG imaging. And then lastly, we have our CT map here to demonstrate where the FDG localizes to. And what you can see in this case is she didn't complain of breathlessness. She didn't complain of shortness of breath or fibrosis. But what you can see is she did have a spotty uptake within her lungs, suggesting she has pulmonary sarcoid. She has mediastinal lymphadenopathy. And she also has cardiac uptake here. And we're able to localize the cardiac uptake to the lateral wall, the basal septum, and the right atrium. This may not, however, be her first run-in with sarcoid, as evidenced by the rubidium perfusion images, which shows this moderate reduction in tracer uptake in the apex and throughout the inferior and anterior septum. What we do when we obtain these images, we then discuss the case with nuclear medicine, who their role here is to report the whole body images, and our role is to report the cardiac images. And then we make sure that there's consistency between the two reports. So as mentioned, Our Lady had heart block secondary to cardiac sarcoid, so bradycardia would be one manifestation of the disease. After the active inflammation, the granulomas become more fibrotic, and patients can be left with reentry ventricular tachycardias. They also may be left with scarring, and as we've said already, some of these patients may actually be asymptomatic. So in terms of, we can pick it up, but how does it help management? So this is the how. How does FDG help in the management of sarcoid? So we find, we can help with the etiology of patients, young patients with complete heart block. So in 2 series, what is the frequency of cardiac sarcoid on these young people presenting with heart block for which you've got no other cause? It's between 1/4 and 1/3 of patients will have evidence of cardiac sarcoid. It also has a role in management. So typically patients, after they've been presented with acute presentation and we demonstrate FDG uptake, they get put on glucocorticoids, prednisone at 30 to 40 milligrams once a day. And then we need to review, excuse me, whether that's been successful. So they get a repeat study in 3 months' time to see if that has resolved. If a patient with sarcoid also presents with tachycardia, such as ventricular tachycardia, we will also repeat the imaging to see if that ventricular tachycardia is due to reactivation of disease. So in terms of our case, this is Our Lady at presentation. She was then managed for 3 months with 30 milligrams of prednisone. And you can see here she's had resolution of a pulmonary sarcoidosis in terms of inflammation. And there's still a mild degree of cardiac uptake, but it's much improved in terms of where she was at presentation. So what about ICDs in these patients, and can FDG imaging influence what we do? So the Heart Rhythm Society has guidelines in terms of management of cardiac sarcoid, and this is their suggestions. So when a patient with cardiac sarcoid has VT, they need to be treated in the usual manner with antiarrhythmics. They may or may not require immune suppression based on their FDG images. There's several things to pick out from this chart at the bottom. So an EF of less than 35%, we might expect that. If patients are undergoing pacemaker implantation, those cases should be discussed with EP to see, well, should we be considering this patient for an ICD, even if the EF is not that bad? If they've had near syncope and we haven't shown heart block, could this be a malignant ventricular arrhythmia? And then if they undergo an EP study and demonstrate the propensity for re-entry of VT, then they should have an ICD. The final point really from this chart here is this last point, and it brings me to my last slide. But if you see that even if you have a moderate left ventricular impairment, but have impairment of the RV, there is a recommendation, at least it's a 2B recommendation, for these patients to be considered for ICD. And why is that? So this is work done from a group in New York, a retrospective review of 120 patients of theirs, and they built a multivariate model trying to assess prognosis, and does FDG PET have a role in prognosis of sarcoid patients? And what they found was that even when you factor in ejection fraction or diagnostic criteria, if you look here, what still remains significant is abnormal perfusion and metabolism, hence the reason why we do relative perfusion imaging in these patients. And finally, the RV uptake was also remained incremental to these other factors in terms of its influence on prognosis. So in conclusion, ladies and gentlemen, we didn't do too badly for time. I hope that I've showed you how nuclear medicine can be complementary to echocardiography in infective endocarditis, cardiac device-related infections, and sarcoidosis. We've looked at how do they do that in terms of diagnosis and management, and I hope that I've given you some food for thought over your lunch. Thank you very much for your time.